الموضوع كتير كبير. احنا نحاول نعطي بوينتس فيه على اهم المواضيع ونحط فلاش بوينتس على المواضيع الكومن احنا بنتعامل مع حدايدي، الاشياء الرير والاشياء اللي اليوجوال يعني صعب نلاقيها اصلا بالاشياء العاديه، ما راح نحكي فيها. كبدايه زي ما بنحكي دائما بنبلش بالاناتومي تبع الني. احنا كلنا بنعرف انه الني هي synovial joint. It is a modified hinge joint. زي ما كنا بنعرف الهنج جوينت في لها one plane اللي هو يا اما flexion extension. الني في لها شيء زياده عن الفليكشن اكستنشن اللي هي في عندها روتيشن. ففي عندنا احنا باخر الاكستنشن اوف ذا ني لما نصير عندنا فول اكستنشن في لوكينج بتصير للني اللي هي الانتروتيشن تبعت الفيمر، فبصير بتعمل لوك للني، بصير كل الويت ماشي على الليجمنتس اكثر من انه مسل ديستريبيوشن. بخفف اللود على المسلز، بكون كل الاستابيليتي كلياتها من الليجمنتس اراوند ذا ني اللي ماسك الني بحد ذاتها. عشان هيك هي موديفايد هنج جوينت. كأي جوينت we have three modality of stability. في عندنا البوني كونفيجريشن اللي هي بني عندنا اياها الكونفيجريشن تبعت الكوندايلز بالاضافه للتيبيال بلاتو، هذول بيعطي around 40% of stability. في عندنا بعديها اللي هو ligaments around the knee, which is the more contributing to the stability of the knee in all directions, flexion, extension. We have four main ligaments. We have the lateral meniscus, lateral collateral ligament, medial collateral ligament, anterior cruciate ligament, and the posterior cruciate ligament. These four ligaments are the main contributing for the stability of the knee. And the third stabilizer of any joint is the muscles around the joint. The main muscles that contribute to the stability of the knee joint is the hamstrings, the flexion, and the quadriceps in extension. And we have the gastrocnemius muscles from the back, little contribution. According to the knee mainly component of three compartments. We have the medial compartment with the medial tibial plateau and the medial condyle. We have the lateral compartment with the lateral tibial plateau and the lateral condyle. And we have the patella. The femoral joint, where the patella is articulating with the distal femur, with the sulcus of the femur, the trochlea, added to the third compartment of the knee. The aim of the patella, as we all know, the patella is the biggest sigmoid bone. Its contribution to the knee is access for less power for the extension of the knee. The patella act as a fulcrum. Fulcrum is ركيزة. الركيزة بالعربي أو بالعلم العتلات اللي هي البيس اللي بتنحط تحت البور عشان نقلل البور needed by the quadriceps to extend the knee. If there is no patella, as in some cases of patellectomy we do after fractures, the quadriceps needs 7 times more power to extend the knee more than the power itself. The patella, it is a fulcrum used to extend the knee. The joint of the patella articulating with the distal femur. It has also its own stabilizer. It has the articulation with the distal femur, the shape of the patella, the lateral facets and the medial facets with the trochlea of the femur. And it is ligamentous. We have the medial MPFL, medial patellofemoral ligament, and the lateral and the medial patellofemoral ligament. We have the medial and lateral tenaculum, and we have the muscles or the tendons of the quadriceps and the patellar ligaments that will contribute and will act to the function and the stability of the patella. Now we will go to the subjects one by one. First of all, we will start with the anterior cruciate ligament. The main act of the anterior or the main function of the anterior cruciate ligament that prevent anterior translation of tibia over the femur. And some kind of questions that may be entered. If you prevent anterior translation of tibia over the femur, it is the posterior translation of femur over the tibia. So don't mess up with this kind of questions. Usually the anterior cruciate ligament is originating from the lateral border the medial border of the lateral femoral condyle. The lateral femoral condyle, we have two borders. We have the medial border and we have the lateral border. So the ACL is originating from the medial border of the lateral femoral condyle, and it will insert on the just anterior to the tibial tuberosity between the two eminences, two tibial, medial and lateral eminences of the tibia. The ACL has two sections. We have the anteromedial and posteromedial bundles. We can divide into anteromedial and posteromedial bundle. The anteromedial bundle is tight in flexion and loose in extension, and the posterolateral bundle is tight in extension and loose in flexion. One will we will have it more when we do the examination afterward. The blood supply of the ACL is usually from the middle geniculate artery. That's why any patients with ACL rupture, acute rupture, will experience some kind of hemarthrosis and immediate hemarthrosis. The innervation of the ACL has a proprioception innervation from the tibial nerve. So one of the modalities that will affect cardiac reduction afterward doesn't have the same proprioception for the originating ACL. The mechanism of injury for anterior cruciate ligament, I will do that in a scenario actually. Usually, 70 to 80% of the patients that I will experience in my clinic is we have a patient, he was playing football. Usually, he had something called non-contact injury. Non-contact injury يعني ما حد ضربه، ما حدا اجى لمسه، هو بيلعب بالطابه، بيعمل حركات فجأة، عمل روتيشن بطريقه معينه وقع على الارض. صار عنده while playing football non-contact injury. هلا هاد ورا هاي non-contact injury he heard or felt a pop زي طقه برجله بركبته. بعديها خلص بوقع على الارض، ما بيقدر يتحمل يمشي، ما بيقدر يتحمل يقوم، بصير بيطلع برا اللعبه، ما بيقدر يكمل اللعبه. المريض اللي بيعمل ACL اللي بيكون عنده ACL تير ما بيكمل الجيم. اللي بيجي بيحكي لك دكتور والله صار معي اصابه وانا بلعب قدم وبعديها صارت توجعني ركبتي. الو صار معك كملت اللعبه؟ بحكي لك كملت اللعبه وخسرنا وفزنا وصار شو؟ بحكي له يعني اغلب هذا mostly more than 99% is not an ACL. المرضى اللي بيصير عندهم ACL بيكونوا very severe onset of pain. ما بيكون البين عندهم عادي، ما بيقدر يكمل، يطلع برا اللعبه، can't continue with this game. يصير immediate swelling، يعني immediate within 30 minutes 1 hour يصير ركبته زي البالون. غالبا هدول المرضى بيروحوا على الطوارئ بيروحوا بيصوروهم. يوجوالي هدول بالاكس راي ما بيبين عندهم اي فراكشرز، ما بيبين اي شيء. طبيب الطوارئ بيحكي له انت يو هاف تو ريست، تحط لها سبلنت، تحط لها وات ايفر، ويو هاف تو ريتيرن تو ذا دكتور. فاول شيء حكينا هذا بيكون عندهم نون كونتاكت انجري. عاده النون كونتاكت انجري بيكون عندهم تيبيا ترانزليت، بصير نتيجتها يسموها بيفترنج انجري، تيبيا ترانزليت انتيريورلي وبعدين سلايت فليكشن اند فالجس. في احيانا ريرلي ممكن يكون بلو ات ذا lateral aspect of the knee، but the most commonly هي non contact bifting injury. زي ما حكينا عاده هدول المرضى بيكون عندهم pain acute onset of pain خاصه اول الاصابه، بعدين بصير عندهم swelling الهيمارثروسس اللي حكينا عنها. he felt or heard a pop in his knee. هلا الشيء اللي بدنا نحكي عنه هي موضوع اللي ايش بيشكي منه المريض بعدين. المريض اللي عندهم isolated ACL بعد اسبوعين 3 اسابيع غالبا البين بروح، البين والسويلنج والهذا كله بروح. ضل عنده مشكله بيحكي لك انه بعد اسبوعين زمان هذول المرضى غالبا بيشيلوا السلاب، بيحكي انا خلاص بطل في عندي وجع، بمشي بتحرك عليها عادي، بروح وباجي. بعد فتره بيجي بيحكي لك دكتور انا بتفلت مني ركبه. طب كيف يعني قصدك؟ بحكي دكتور انا طالع درج بحس انها بتخونني، بدي اوقع، بصير بدي اوقع. في sensation of instability، هي الاكزامينيشن او الميديكال تيرم تبعها هي given way. المرضى اللي عندهم sensation of instability بنسميها giving way عندهم دول المرضى. فالمين كومبلين او المين اكشن تبعتهم according to their symptoms اللي هي giving way. هدول بيجي على العياده بحضرها بيحكي دكتور انا صار معي هيك اصابه وصار الامور عندي كويسه ممتازه، ما صار في عندي وجع، راح الوجع راح كل شيء، بس هلا المشكله تبعتي بس انه انا لما اطلع درج انزل درج، لما اعمل حركه معينه بتصير بحسها بتوجع. هاي هي المشكله اللي احنا عاده بنواجهها، او هذه هي الكومبلين اللي احنا عاده بنحله للمريض. هلا عاده هذا المريض لما يجي على العياده بعد ما ناخذ منه هيستوريفيزيكال اكزامينيشن we do for them some tests. First test we do for them is the Lachman test. Lachman test usually the Lachman test is usually done with the patient supine. Sorry, this is the anterior drawer. I will go for the Lachman test. يوجوالي هذول المرضى تبعون اللخمن تيست او زي ما حكى لك بالفيديو we have to put the patient in 20 to 30 degrees. Sometimes it is hard to hold the thigh or the femur from your hand or your wrist hand. So we can usually put our leg beneath the thigh and we control the thigh in that manner and put the left hand above it, and we can manipulate with the right one. The positive test, you feel the knee is moving with you. When you translate it anteriorly, all the femur is going up. Patient with intact ACL, you feel something called catch in, or the thigh or the knee is not pulling up with you. One thing about the femur, as I told you before, we have two bundles. We have the anteromedial bundle and we have the posteromedial bundle. The posterolateral bundle. The anteromedial bundle is tight in flexion and the posterolateral is tight in extension. Usually in this examination, you can examine the posterolateral bundle more than the posteromedial bundle. The other test, the more common test is the anterior drawer test. This test, usually we examine for the anteromedial bundle. Excuse me, this is now in this position, as I told you, when you do this one and you translate, try to pull the tibia anteriorly, you will notice the translation of the tibia anteriorly. This is the anterior drawer test. One of the most sensitive tests is called the pivot cuff test. It is highly sensitive, highly specific for ACL. The problem, it is painful for patients. Usually we do this test in the ER before the ACL reconstruction surgeries. كمان مره هو التست حاله المريض when it is full extension we do internal rotation of the lower limb. We do valgus stress. We bring the knee from full extension to flexion. In this time, if the patient has an ACL, you will feel a relocation of the tibia, because when the ACL is torn, the tibia will go down. So when you do this test, you will relocate the tibia. You will hear or feel something like a clunk. So you feel the relocation of the tibia to this position. So with these patients, usually when he come, we can do an X-ray for imaging for him. Usually the X-ray is normal. In some sort or some rare cases, we may have some kind of avulsion of the tibial tuberosity at the site of insertion of the ACL, and this mainly we can see it in young patients. And other way, we can see some kind of Sigon fracture. Single fracture is a chippy fracture on the anterolateral aspect of the proximal tibia, usually associated with ACL. This is pathognomonic for ACL. It is rare to see these kind of X-rays. Usually the X-ray is normal. The gold standard examination for the anterior cruciate ligament is the MRI. This is the view in the MRI. Normally we can see with a patient with intact ACL. You can see the fibers are oblique, going from the femur to the tibia. This is intact with no signs of disruption. Patient in ACL tear or ruptured, you cannot see the ACL in this manner. This is the PCL. This is the PCL. Usually in patients with ACL tear, we have some kind called slag PCL or redundant PCL. Other 10 things that can be done in this patient can be seen in the MRI. Some kind of bone bruises, usually on the lateral side, on the lateral femur condyle and lateral tibial plateau. It's present on 50-70% of the patients. That's also it's kind of pathognomonic for PCL for ACL tear. Now, what's the treatment of patients with ACL? We have, we can going according to patient's condition. Some patients will tell you, I'm a lazy patient. I don't do open sports. I work as a computer engineering or computer science. All the time I'm sitting on my desk. I don't do any activities. Then we can go for him for non-operative treatment. This kind of non-operative treatment, we do physical therapy. We strengthen the hamstring muscles. The hamstring muscles work as a secondary stabilizer of the knee for the translation of tibia over the femur. It's not strong as the ACL, and it's not in all direction, but it may contribute well to the stability of the knee. The outcome usually is good, but the problem with the patient with ACL tear, it has a increased risk of medial meniscus tear. So patient young age group and patients with athletes or high activities, usually we do him an reconstruction for the ACL. The reconstruction, we bring an allograft, autograft. We may have autograft the hamstring tendon, the gracilis and semitendinosus. We bring them and we insert them inside the tunnels between the tibias and the femurs. This is in arthroscopic manner. This is called ACL reconstruction. Usually, in the past, they used to do an ACL repair, but unfortunately, there is no repair for patients with ACL. Now, new modes of repair is doing a repair on the original ACL according to this is detached from the femur, and they put some kind of scaffold and blood clots around it. Still, the results of this kind of treatment is unknown. But usually, the gold standard now for patients with ACL is the ACL reconstruction. And usually, afterward, we do an physiotherapy for him so that we can assure he can go to his physical activity, and he can go to his previous sports after the physiotherapy. The physiotherapy usually starts from needs at least 4 to 6 months, and some studies needs almost 9 months intensive physiotherapy so that the patient can go to his original playing type. After the ACL, now we can go to the PCL. The PCL, it is prevent the posterior translation of tibia over the femur. It is originated from the lateral border of the femur condyle, and the insertion on the posterior aspect of the tibial sulcus. Also, we have two bundles, the anteromedial and the anterolateral bundle, and the blood supply also from the medial geniculate artery. The PCL rarely present as a solo. The mechanism of action of the PCL, it is mostly a dashboard injury. Dashboard injury is when you sit to in the front of the car, when you have a head-to-head collision with another car, it is automatically you bring your knees upward so that the bottom of the knee will hit the dashboard of the car. This can do a patellar fracture. This can do a femur fracture, a hip dislocation, a stapler fracture. It also can do an PCL tear or PCL injury. This is the most common mechanism of injury. Also, it can be non-contact hyperflexion of the knee with the plantar flex foot, or in hyperextension injury, which is also a rare mechanism of action. Usually, the PCL when it's stored, we have to check for lateral collateral ligament and something called posterolateral corner. It is a rare condition, and usually it doesn't have in solo. The patient complaining of some kind of posterior knee pain and instability, some kind of giving way. The test for the PCL is the posterior drawer test. We can check for this one. And after that, we can do an X-ray for the patient. The X-ray for the patient, usually it is normal unless there's an avulsion fracture like in the ACL, like in this one. And patients also, the gold standard is the MRI. The MRI will show the disruption of the PCL. The PCL is from here to here. So you can see the disruption in this place. This is indicating a PCL tear. Usually, we can start with the patient with non-operative treatment with physiotherapy and protective weight bearing. Usually, they have some kind of assortment and adaptation for this treatment. And the operative treatment is the reconstruction with autograft or allograft to the original site of the PCL. Also afterwards, he had rehabilitation so that he can again to work or to his activity. The two things now to go about to talk about is the meniscus or the menisci. We have in the knee two menisci. We have the medial and the lateral menisci. The menisci are the medial meniscus is semicircular or the lunar shape, and the lateral meniscus is almost circular in shape. The medial meniscus composed of posterior horn, body, and anterior horn. The medial meniscus is attached to the capsule, while the lateral meniscus not attached to the capsule. It make it more freely. Because the meniscus is attached to the capsule, it increases the risk of tear in the meniscus, on the medial meniscus, more common than the lateral meniscus. The meniscus has also we can classify the meniscus according to its blood supply. Usually, the blood supply from the medial or lateral or middle geniculate artery. The artery will go to the peripheral zone on the meniscus. We call it the red zone. Then we have an area where there's vascularity, and without vascularity, we call it the red-white zone. And on the central part of the meniscus, we call it the white zone. The problem, the white zone has no vascularity. The rate of healing is almost zero. If there is a tear on the area on the peripheral zone, there is some kind of repair, fibrous repair, may can contribute to the structural integrity of the menisci. So the peripheral border is thick and attached to the capsule. The inner border is thin and concave, forming a free edge. The upper surface are in contact with the femoral condyle, and the lower surface are in contact with the tibial condyle. Medial menisci is semicircular, but the menisci is almost a complete circle, as we see before. So, what's the function of the menisci? The meniscus is it's deep in the articular surface of the tibial condyle to receive a convex femoral condyle. The most important thing is transmit the load, not to come to one point from the femur condyle. It transmits the load all over the surface of the knee, thus reducing the load per unit area on the tibial femoral contact, all of us like a cushion of the joint. Each meniscus is attached to the upper surface of the tibia by the anterior and posterior horn, because the medial meniscus is also attached to the medial collateral ligament. It's relatively immobile. The lateral meniscus is free and mobile. Now, what is the mechanism of injury for menisci? Usually, it is acute twisting injury from impact during a sport. Usually, the foot stays fixed on the ground and the rest of the body rotates. Getting up from a squatting or crouching position, loading knee from a fixed. Usually, the symptoms of the patient with knee pain, the most common when he had this injury, he will complain from medial or lateral knee pain. He will have some kind of mechanical symptoms, the locking. When the meniscus will go from its side to go inside the joint, it will lock up the condyle of the femur to articulate with the tibia. That will cause some kind of locking. The locking and catching, especially with squatting, and sometimes kind of swelling. The difference between the swelling from the medial meniscus and the swelling from the ACL, the swelling from the ACL usually it is acute. It happens within half an hour, 1 hour, 2 hours, 3 hours. But the swelling or the hematosis from the meniscus, usually it is maybe more. It will need maybe 1 day or 2 days to have the swelling. Usually, the patient will come after 1 day or 2 days. He told us that I have a swelling in my knee. So, what's the examination for patients with meniscus? Usually, the joint line tenderness is the most sensitive physical examination findings. In patients with medial meniscal tear, medial joint tenderness, we will have it. It is sensitive, but it's not specific. And a patient with arthritis will have the medial joints, or will have a joint line tenderness. And one of the tests is the McMurray test. We have the McMurray test, original McMurray test, and the modified McMurray test. You can see it in this video. Again, I will do it again. I will explain it again. When you do in McMurray test, you have to do a full reflection. You do external rotation, valgus, and then extension. This is how we can examine for medial meniscus. For medial meniscus, we do full reflection, external rotation, valgus, and extension. In lateral meniscus, we do the other way. We do internal rotation, varus test, and then extension. This is for the lateral meniscus. Now we have also the apply-grinding test. The problem apply-grinding test is not specific as McMurray. Sorry. This time the patient is prone. It is not fine. For meniscus, you have to apply axial loading and external and internal rotation. For ligamentous, sometimes you have a ligamentous, we do extraction. The recently added test is the Thesty test. The Thesali test is not also specific and hard to accommodate with the patients. So this is the examination for patient with meniscal injury. Now we have to classify them. We can classify the meniscal injury according to the location or the position or the size. The location, as we said before, if it is red or red-white or it is in the white zone. We can according it is in the anterior horn, the body, or the posterior horn, or according to its large or small size. We can locate it according to its shape. Could be a vertical, a bucket handle tear like this one and this one. It has an oblique peak shape, parrot shape. We have the radial and we have the horizontal. This is the radial. We can have the horizontal and we have a complex tear. And sometimes we have a root tear where it is originates from the posterior part. This is the root of the meniscus. And it is devastating. So what is in the X-ray? It will appear normal. In MRI, we have like this one, the disruption of the medial meniscus. We can say it is a double PCL sign in medial meniscus tear. As you see here, this is the meniscus and this is the PCL. And sometimes we have a double anterior horn as this one. So this is an MRI scanning, and the gold standard is the arthroscopy to detect the actual. This is about 95 to 97%, but the arthroscopy is the 100% for the tears. What is the treatment for meniscus? We have non-operative treatment by rest, non-steroidal, and rehabilitation. It's indicated as a first-line treatment for degenerative tears. But in patient with locking, also it is advisable to do arthroscopy if there's a locking, not only the pain. If there is a locking, if there is a continuous or pain or chronic pain, we can do arthroscopy for them so that we can do either partial meniscectomy. This is done in the peripheral tear, in the white zone area, sometimes in the white zone area. If there is a complex tear and if there is a mark This is the patient with meniscal tear on both sides. This is how to return in partial meniscectomy. The other way is to do a meniscal repair. This is the tear in the peripheral red zone, in vertical and longitudinal tear, usually in the root tear. It is also if the patient has this injury with the ACL reconstruction, usually successful in 60 to 80%, not that high, unless it is in the red zone and it is a clear one. It is high. Now I have to stop because we have run out of time. بدي اطلع وارد ارجع نرجع على نفس لا اعمل واحد ثاني disorder or dislocation maybe. As we said before, the patella is the largest sesamoid bone. It articulates with the distal end of the femur, with the trochlea of the femur. We have two facets for the patella. We have the lateral facet, the larger, and we have the medial facet. As we said before, we have two main ligaments on the medial side, the medial patellofemoral ligament and the medial patello-tibial ligament. And we have for stability, the medial and lateral retinaculum, the action of the quadriceps. For the quadriceps, it will move the patella upward. It will move the patella upward, and in the flexion side, when you do flexion, the patella will go, other than upward, it will go in this direction. And the patella will go to the lateral direction. What prevents the patella to dislocate on the other side? We have multiple items. We have the femur, that, as we know, the lateral femur condyle is more prominent anteriorly. So it will prevent the patella to go laterally. And what prevents also the patella to go laterally is the ligaments, the medial patellofemoral ligament, and the medial patellotibial ligament, and the medial retinaculum. This cause that will contribute the stability for the patella. The action of the quadriceps, or the moment of the quadriceps, we call it the Q angle. The Q angle in the patella, we go from the center of the patella, the anterior superior iliac spine. We draw a line, and this line will go with another line from the center of the patella to the tibia tuberosity. This line will cause an angle. This angle, we call it the Q angle. It is normally less than 15 degrees. Now, as we said before, from the anterior superior iliac spine to the patella, this is the moment of the quadriceps muscles, and from the tibia tuberosity, from the center of the patella to the tibia tuberosity, this is another line, usually normally in less than 15. In females, usually the pelvis is wide, so the anterior superior spine will go more lateral. So that will increase the Q angle. Any patellofemoral disorder usually is more common in females, and this is one of the contributing factors. What is the risk factor for patellar dislocation? First of all, we have general factors like ligamentous laxity in patients with patellar dumbness. Previous patellar dislocation, we have something called miserable malalignment syndrome, high femoral anteversion with the genovalgus and pronated feet or flat feet, kind of external tibial torsion. This will increase the Q angle. These three items is the risk factor for malalignment syndrome and increase the risk of patellar dislocation. What is the anatomical factor? In case the patella is high, we call it patella alta. It will not articulate with the sulcus, and it will easily go to the lateral side. If there is a dysplasia in the trochlea, or is the hypoplasia of the lateral femoral condyle. So what is the mechanism of injury? Usually it is non-contact injury. Usually it is in second decade of life. Female patients, an adolescent female patient, will exhibit non-contact twisting injury with the knee extended and the foot externally rotated. The patient will usually reflexively contract the quadriceps, reducing the patella, and it will dislocate the patella laterally. This commonly when you have a direct trauma to the patella, which will slide the patella to the lateral side. So the patient will complain of instability and pain to the patella and anterior knee pain. We can do an acute dislocation. You will have some kind of hemarthrosis, large hemarthrosis. You will notice medial side tenderness over the medial patellofemoral ligament. Here the medial patellofemoral ligament. Here the medial patellofemoral ligament. You can have tenderness. And we can do the patellar apprehension test. The patellar apprehension test
the patellar apprehension test, the patient lies supine with 30 degrees of knee flexion and the quadriceps relaxed. If the patient suddenly contracts the quadriceps, the test is considered positive for a subluxing patella.
احنا بنسميه الفيديو هو الفكره في الموضوع ان نخلي الني من 30 degrees almost. We try to dislocate the patella laterally. عاده المريض اللي عنده patella dislocation مش راح يخليك تكمل التست. هيك توقف او he will contract the quadriceps as a protection for his patella. هذا البوزيتيف عاده هذا البوزيتيف test for patella apprehension. The usual X-ray for patient with patellar instability or patellar fracture, dislocation. Usually we can notice the patella outside, and usually it is out from this view. It is the sunrise view. We can notice the patella it is outside of the femur or of the sulcus. Usually the treatment is we give the patient sedation and we relocate the patella itself. The acute symptoms of the first time dislocation, we usually put a patient slab for almost 1 month. Then we remove the slab and we enhance the strengthening of the vastus medialis for rehabilitation for that patient. Patient with recurrent patellar dislocation, we have to address the problem with the patient. As we saw before, in the risk factors, we have to see as any of the risk factors. We have to address what the patient have the risk factor, so we can treat this risk factor if it is anatomical or some kind of malalignment syndrome, or it is just a simple dislocation or traumatic dislocation. We can do either non-operative, as we said before, non-steroidal active modification, physical therapy. The operative medication, operative treatment for patellar dislocation, recurrent patellar dislocation, is the first one is the MPFL reconstruction, medial patellofemoral ligament reconstruction, or if it is acute, we can do repair, but it's not that good option. We can do some type of osteotomy. This is called the Falkison osteotomy. We do tibia tuberous transfer, medial and anterior. We can do lateral release and trochleoplasty, some kind of method. Sorry. Is there any question now from now and from the previous lecture? شباب عبد الله ان شاء الله خير ان شاء الله. هلا رح ندخل على the other part of the seminar. It is the swelling around the knee. Swelling around the knee, we can define either it is from the entire joint, or it is in the front of the joint, or behind the joint, or at the side of the bone, or it is bony swelling. We will start with swelling of the entire joint. We can classify it either it is acute or chronic. Patient with the acute, we can go with hemarthrosis. The cause of hemarthrosis, either it is traumatic, patient had ACL, menisci, PCL, will exhibit, or some kind of fracture. Either the knee joint will exhibit hemarthrosis, or it could be due to coagulation problem like patients with hemophilias. Some kind of acute swelling per joint is the septic arthritis, and you have a full lecture for septic and for septic arthritis, including chronic septic arthritis. And for chronic swelling of the entire joint, could be a non-infective arthritis, like in patients with rheumatoid arthritis, patients with osteoarthrosis. It can exhibit some kind of fusion inside the joint. We can have chronic infective arthritis like patients with TB, or some kind of tumors or benign tumors. We have the synovial chondromatosis. It is multiple purely cartilaginous loose bodies enveloped in the synovial fluid, will cause some kind of swelling around the knee or inside the knee, or an entity called pigmented glomerular synovitis. It's a term, some type of synovitis or benign synovitis in the joint. This is a synovial tumor which causes erosion of and excavation of the articular surface. At operation, the synovium is seen to be swollen, often covered with villi and gold brown in color, the effect of hematosm deposition inside the joint. And the other entity, we have swelling in front of the knee. As we all know, the knee has almost more than 10 bursas. What is the bursa? Bursa is a reflection of the synovial membrane. It has double layers. It prevents the cracking or the الاحتكاك تبعتها بين البون or the tendon to the skin to protect the tendon or the bone from the احتكاك تبعهم، ما يصير في بيناتهم collusion او احتكاك بيناتهم. ففي عندنا بالني اكثر من 10 burses. Usually اللي كمان انه يصير في احيانا احنا بنسميها bursitis, inflammation inside this bursa. The most common part is we call it the house knee bursa اللي هي the prepatellar bursitis. This prepatellar bursitis عادة هذول patients usually they used to kneel and while they are kneeling they are walking on the knee. زي الناس الايام زمان لما كانوا الخدامات او هذا يعني ينظفوا الارض يقعدوا على الارض with their knee on the stand. هذا بيعمل hypertrophy inflammation جوا السينوفيال membrane. هذا بيعملها بورمها بكبرها بصير في عندهم pain فيهم في swelling فيها. غالبا هذول عاده التريتمنت تبعهم كونزرفتيف بس نعطيهم نون ستيرويدال نعطيهم لهم ايس. هلا المشكله في مشكلتين فيها، واحد يضل عنده كرونيك بين والسويلنج اللي موجود فيها، او في مريض صارت انفكتد جوا البيرسون نفسها. لا اذا كانت كرونيك عاده بنعمل لهم اكسجين لها. اذا كان صار فيها انفكشن هاي زي abscess you have to do incision and drainage for them and after a while you have to do excision of the bursa. Then for patellar bursitis is present here in the site of the patellar tendon and it prevents the sliding of the patella to the patellar tendon to the skin, the flexion of the patellar tendon to the skin, also the same as the house knee bursa, and this is less common than the house-made bursas. Swellings at the back of the knee usually can be a semimembranosus bursa as the previous one. The most common one and the most possible one is the popliteal cyst or the Baker cyst. Usually the Baker cyst is secondary to a problem. Usually the rheumatoid arthritis or osteoarthritis patient, the capsule of the joint, the posterior aspect will have a defect. This defect will let the synovial membrane and the synovial fluid to go out from this capsule to do a synovial cyst or what we call a Baker cyst. Usually it is very common. Usually the treatment is conservative. You have to treat the underlying cause, the rheumatoid arthritis or the osteoarthritis, sometimes the meniscus tear. And usually it will subside by itself or go upward by itself. If you excise it, it will relocate from another side. So usually we don't do excision for any patient with synovial cyst. Rarely, if there is a cyst and it is bothering the patient with severe pain, usually we can do an aspiration for this cyst and injection it with corticosteroids in this area. And one of the swellings on the back of the knee is the popliteal aneurysm. The swelling at the side of the knee, we have the meniscal cyst. It's like our ganglion. We can have some rare entity called collateral calcification of the collateral ligament, like this one. Or there is a bone swelling, the exostosis, some kind of osteochondroma on the side. You took the subject with benign bone tumors. And The last thing about this seminar is the Osgood-Schlatter disease, or the tibial tubercle apophysitis. Normally, the tibial tuberosity is not an articulating, so we call it the apophysis. It is the attachment of the patellar ligament on the anterior proximal part of the tibia. This insertion, this tibial tuberosity will have secondary calcification according to the age. Usually in males, the calcification happens between 12 and 15 years, and the females from 8 to 12 years. Due to pull of the patellar tendon and the strong quadriceps muscles, you will have some kind of traction on this apophysis. We called it tractional apophysitis or osteochondrosis at the tibial tubercle. This is traction. Afterward, we will cause some kind of minimal fracture at the site of the tibial tubercle. The patient or the young adolescents will complain of anterior knee pain, mainly after exercise. This patient, usually it is in male more than the female. In male, it's present usually at the age of 14. Female, it's present almost at the age of 10. This is a common problem. In physical examination, you will notice the enlargement of the tibial tubercle, and the most sensitive test is the tenderness over the tibial tubercle. In the X-ray, you will notice some kind of fragmentation at the site of the insertion of the tibial patellar tendon to the tibial tubercle. Usually, the treatment is non-operative with non-steroidal anti-inflammatory medication, activity modification. Some sites, the patient have severe symptoms, not responding to conservative management, we can do cast immobilization for 6 weeks. This cast immobilization is usually, it will decrease the strength of the quadriceps muscles. So it is very useful in patients with propagative symptoms. Rarely we can do operative treatment. The area of the ossicle is a skeletally mature patient. It will bother the patient when he kneels. عادة من هذول بيجوني مرضى بالثيرد ديكيد اوف لايف 27 28 30 سنه بهيك دكتور انا لما اسجد بصير عندي مشكله وجع بالمنطقه هاي، فغالبا بتكون نتيجه الاوسيكل. هاي الاوسيكل هي الاوتوجراف من التيبيال تيوبروزيتي، فغالبا هذول اذا كان سيفير بين عاده بنعملهم اكسجين لهاي الاوسيكل. ودمتم. في اي سؤال؟
يعطيك العافيه دكتور.
يعافي عمركم. وصار العدد اكثر، صار 32 والله كويس. في حدا صار طيب والله كويس صار زي هيك. صار 33 ممتاز 33. من وين هدول بيجوا؟ ولا ناس ثانيين يدخلوا بزياده؟
دكتور سمحت سؤال.
ايش؟ يلا يعطيكم العافيه. تفضل مدار.
دكتور مش الابريهنشن تيست بالشولدر كمان؟ مش في
ابريهنشن؟ المعنى ابريهنشن يعني انه يعني معناها انه بخاف من الاكشن. في مزبوط ابريهنشن تيست بالشولدر.
عنده